So Dr. Cannon I don't see Dr. Cannon is on, so I will be chairing this meeting until he comes. For the first item on the agenda, if we can have the approval of the minute.
Move to approve.
Thank you, Dr. Turner. Anyone second?
I'll second.
Thank you, Dr. Hoffman. All in favor?
Aye.
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 Any opposed? Okay. Motion passed to approve the minute. Look like I saw Dr. Cannon is just come on. And also Dr. Siegfried, we are having quorum. If you would like to drop off, it's up to you. Thank you very much for coming. Dr. Cannon, since you're here, I will pass the chairing the meeting back to you. We are at the housekeeping item.
All right. So I'm assuming you or Jen or someone have housekeeping. Is that correct?
Yes, Yoon will be Dr. Kim Butterfield will be giving the housekeeping item update today.
Hi, all. Thanks for joining us this morning. I hope that everybody's new year is starting out well. We have just a couple of things. One is just a reminder that our legislative session is starting up this coming week. So we are very excited to see kind of what that brings with it. Hopefully some good things for Medicaid and Medicaid pharmacy. The second is that, fingers crossed, if all continues to go well, we should have the results of our carve-out study within the next few weeks here. And hopefully we'll be able to share those results with you the next time we meet, if not sooner. So that's it for me.
All right. Thank you. With that, let's turn things over to the University of Utah. We have a discussion about, or a presentation around Lantidra, if I said that right. And so, Monet, you just came on camera. I'm guessing it's yours.
Yep. All right. Good morning, everybody. I'm really excited to be starting off the new year talking about this topic. So today I'll be reviewing donidalorsen or Lantidra, the first FDA-approved islet cellular transplant for patients with type 1 diabetes mellitus. Type 1 diabetes is a heterogeneous endocrine condition characterized by destruction, usually autoimmune mediated, of insulin-producing pancreatic beta cells, ultimately leading to complete endogenous insulin deficiency. Type 1 diabetes is attributable to approximately 5 to 10% of all diabetes mellitus cases, and onset can occur in children and adults. Without chronic exogenous insulin therapy delivered either by multiple daily injections or an insulin pump, type 1 diabetes is life-threatening. Despite adherence to insulin therapy, some individuals, such as those who experience recurrent severe hypoglycemic episodes, may struggle to attain the glycemic control required to prevent or delay the onset of diabetes-related complications. Among the 1.2 million people with type 1 diabetes in the U.S., about 25% experience hypoglycemia unawareness and 66% have recurrent severe hypoglycemic episodes, both of which can make it increasingly difficult to achieve glycemic control. Prior to donidalorsen approval, islet cell transplantation has been studied as an experimental procedure in the U.S. for decades to restore endogenous insulin production in patients with type 1 diabetes. Donidalorsen is a single company's preparation of an allogeneic islet cellular transplant product. Of note, donidalorsen was granted orphan drug designation, thereby allowing 7 years of market exclusivity, and is classified as a biologic drug and not a transplant organ. Donidalorsen was approved by the FDA in June 2023 as the first allogeneic deceased donor-derived pancreatic islet cellular treatment for adults with type 1 diabetes who failed to achieve hemoglobin A1C goals due to recurrent hypoglycemic episodes despite intensive diabetes management and education. Treatment with Donidalorsen entails a single infusion given over approximately 30 minutes into the hepatic portal vein. Up to 2 additional infusions may be given for patients who still require exogenous insulin within 1 year of a previous infusion or within 1 year after losing exogenous insulin independence, regardless of the duration from the prior infusion. Healthcare providers specialized in islet cell transplantation should oversee the administration of Donidalorsen within a controlled aseptic environment. Notably, treated patients are expected to continue insulin treatment until reaching insulin independence, which may be as short as several weeks after the Donidalorsen infusion. However, response among recipients is variable. Donidalorsen should be used with steroid-sparing immunosuppressive therapy, including pre-procedurally and lifelong post-infusion to minimize the risk of islet graft rejection and maintain islet cell viability. Donidalorsen prescribing information recommends certain pre-procedural and long-term immunosuppressive regimens, although alternatives may be selected at the discretion of the treating physician. Although immunosuppressive therapy should be continued permanently after receiving Donidalorsen, there are certain scenarios that warrant discontinuing immunosuppressive therapy, as outlined on the bottom half of the slide. Physicians should monitor specific parameters during and or after the Donidalorsen infusion, including portal pressure, blood glucose, and formation of portal vein thrombosis. Notably, Donidalorsen prescribing information recommends stopping the infusion for patients who experience a portal pressure greater than 22 millimeters of mercury for longer than 10 minutes. Patients should be monitored in the hospital for at least 24 hours after the infusion. Reviewed guidelines by the American Diabetes Association, or ADA, and the National Institute for Health and Care Excellence, or NICE, and consensus or position statements by the ADA and the European Association for the Study of Diabetes, or EASD, and the Association of British Clinical Diabetologists, or ABCD, do not yet address Donidalorsen specifically, as they were published prior to its approval. However, these guidelines and statements do provide guidance about islet cell transplantation in general, which may be applicable to Donidalorsen. In general, islet cell or pancreas transplantation is typically reserved for adults with type 1 diabetes and severe metabolic complications despite optimal management, or those simultaneously undergoing or who have received a renal transplant. In addition to severe metabolic complications and severe diabetic chronic kidney disease as indications for islet cell or pancreas transplantation, the ADA and EASD specifically state that islet cell transplant is indicated for those with excessive glycemic liability and recurrent level 3 hypoglycemia, defined as a hypoglycemic episode that requires treatment assistance from another person for recovery. Because islet cell transplantation is less invasive than whole pancreas transplantation, the ADA and EASD state that islet cell transplantation may be suitable for patients who are ineligible for pancreas transplant, including older adults or those with coronary artery disease. Patients undergoing a renal transplant may be more likely to receive a simultaneous pancreas transplant, given that is the gold standard for patients with type 1 diabetes and severe diabetic chronic kidney disease. The FDA approval of Donidalorsen was based on 2 non-randomized prospective single-arm open-label trials, including a phase 1-2 study, UIH-001, and a phase 3 study, UIH-002. Both trials were conducted at a single center and had similar methodology, allowing for a pooled analysis of the safety and efficacy outcomes. To be eligible for either study, participants had to be at least 18 years of age and have type 1 diabetes for at least 5 years. Despite intensive insulin management efforts, UIH-002 also required participants to experience at least 1 episode of severe hypoglycemia within the previous 3 years and have a history of hypoglycemia unawareness, whereas UIH-001 required at least one of the following complications: hypoglycemia unawareness, at least 2 episodes of severe hypoglycemia or DKA-related hospital visits within the previous year, or progressive diabetes-related microvascular complications. Across both studies, a total of 30 adults with type 1 diabetes received at least 1 donidalorsen infusion, up to a maximum of 3 infusions. Each study included a minimum follow-up duration of 1 year after the previous infusion, with the option for additional follow-up at 5 and 10 years. Overall, 25 participants achieved any duration of insulin independence, defined as no longer requiring exogenous insulin treatment. The duration of insulin independence ranged from 4 days to 12.9 years after receiving 1 to 3 infusions. Of these, 4 participants sustained insulin independence for less than 1 year, 12 participants for 1 to 5 years, and 9 participants for greater than 5 years. As of April 2023, 4 participants, or 16%, maintained insulin independence, ranging from 11 to 17.6 years after their first infusion. The safety analysis from the FDA included all participants enrolled in UIH-001 and UIH-002, followed for a mean duration of 6.5 years. In total, 27 of 30 participants experienced at least 1 serious adverse reaction, usually caused by the infusion procedure or concomitant immunosuppressive therapy. The most common immunosuppression-related adverse events that resulted in a serious reaction were infections and malignancy. The main causes of a serious infusion procedure-related reaction were liver laceration, hematoma, intra-abdominal bleeding, hemorrhage, and increased portal pressure. 8 participants discontinued immunosuppression, either temporarily or permanently, due to certain adverse reactions, often including infections or malignancies. As a result, these participants eventually experienced islet cell function loss and insulin non-independence if applicable, but the exact time frame of losing islet cell viability upon discontinuing immunosuppressive therapy is unclear. Overall, the most common adverse reactions from the initial infusion through 1 year after the final infusion were fatigue, nausea, anemia, and diarrhea. Labeling for donidalorsen recommends not administering it to patients with conditions that are contraindicated to immunosuppressive therapy, such as pregnancy, or to the infusion procedure. Donidalorsen carries warnings for concomitant immunosuppression risks, procedural complications, increased risk of islet graft rejection, transmission of donor-derived infections, and increased panel-reactive antibodies. Before being treated with donidalorsen, patients should receive appropriate vaccinations, particularly live vaccines. In addition, patients should receive prophylaxis for pneumonitis, pneumonia, and cytomegalovirus immediately after the donidalorsen infusion, and continued as directed according to the anti-infectives prescribing information. Considerations for prior authorization, or PA criteria, are summarized on the next 2 slides. With respect to PA criteria for patient eligibility, the DURB board may consider reserving donidalorsen for patients matching the FDA-approved indication, including adults with type 1 diabetes who have failed to achieve hemoglobin A1C goals due to recurrent severe hypoglycemia, despite intensive diabetes management and education. An explicit definition of intensive diabetes management is not provided in the donidalorsen prescribing information nor in the FDA review documents regarding the donidalorsen clinical trials. Yet, prescribing information hints that intensive diabetes management should include insulin, devices, and education. Therefore, we infer that patients should explore a comprehensive array of insulin management therapies, including education and other advanced technologies for managing hypoglycemia, such as automated insulin delivery systems, prior to considering donidalorsen, especially given the risks of long-term immunosuppression. When determining suitability for islet cell transplantation, the 2020 ABCD position statement notes that it's preferred for patients to have previously trialed an insulin pump and continuous glucose monitoring, but this is not required. Notably, there is no evidence of donidalorsen benefit in patients with hypoglycemia unawareness capable of preventing repeated severe hypoglycemic episodes while using intensive diabetes management. Due to the risk of concomitant immunosuppression to a fetus, consider recommending the provider monitors the patient's pregnancy status before and after each Denizlicel infusion. Additional PA criteria may be considered to ensure that Denizlicel is prescribed by or in consultation with a healthcare provider specialized in islet cell transplantation, and that the dosing of Denizlicel meets the FDA labeling requirements with the allowance of up to 3 lifetime infusions. May consider provider attestation that the patient will receive concomitant immunosuppressive therapy consisting of a steroid-sparing regimen and appropriate antibiotic prophylaxis after the infusion. Regarding criteria for a second or third Denizlicel infusion, consider allowing additional infusions for patients who do not achieve adequate glycemic control while taking the prescribed immunosuppressive therapy and who still require exogenous insulin within 1 year of a previous infusion or within 1 year after losing exogenous insulin independence. Additional considerations may include that the patient has received all necessary vaccinations before starting Denizlicel, the patient has a negative T and B cell cross-match, the patient does not have an active infection, malignancies, a high risk of bleeding, or liver disease, and that the provider has discussed with the patient and appropriately weighed the risks and benefits that Denizlicel may potentially increase panel-reactive antibodies and thus negatively impact future renal transplant eligibility. This concludes the presentation. Please let me know if you have any questions. Thank you for your time and attendance.
Okay, I'll open it up for questions. I guess, Monet, I just for my own clarity, you know, we talk about in both of these trials, patients having hypoglycemia unawareness, hypoglycemic unawareness. Can you define that so that I make sure that I'm understanding that correctly? Is that simply that the patient just is not aware? I mean, because I mean, as they start to have hypoglycemia, at some point they're aware. But help me understand that. Judith is shaking her head. So for the pharmacist in the room, help me get that.
Yeah, sure. So typically hypoglycemia unawareness is defined, how they defined it in the clinical trials was that it was a self-reported lack of appropriate autonomic symptoms when the blood glucose levels decreased below a certain level, and that was typically 54 milligrams per deciliter. So they should be having, signs that their blood glucose is decreasing, but sometimes these patients don't have the appropriate symptoms that indicate that it's decreased.
And Dr. Turner shaking her head, so I'm feeling good about that. So I guess then the next question is, had any of these patients been, I mean, we're talking about so few patients, had any of them been on continuous glucose monitoring? Had any of them been on pumps? You have that built into the recommendation on your criteria there.
Yeah, that's actually a really, really good question. I know in the inclusion criteria, they didn't specifically state, that patients had to have had been on, using an insulin pump or anything like that to be eligible for the studies. So as far as I'm aware, I am not sure actually about that, because from what I could tell, they didn't report that.
Okay. Other questions from the group?
Hi, Monet. This is Neil. Great presentation this morning. Happy New Year to everyone. And a question on the malignancies. On the trials, it looked like, if I read that correctly, a third of patients, or over a third of patients, it was a concern for malignancies. Did it state what type of malignancies?
So are you talking about on the safety section?
In the safety section, yeah.
Okay. I can't remember off the top of my head
Okay.
if they stated that, because a lot of these trials I had to go through the FDA documents to figure out specifics. But I am not sure on that. I would
That's
have
okay.
to go back and look.
I'd have to look, maybe I misinterpreted the slide a few slides back here on
Um,
that 37%, but I just seeing if there was anything that
I
jumped
thought
out
it was
to
on
me.
the slide.
Slide 8.
Sorry to jump in, but I caught that too. I thought that was on the slide,
Okay,
that it named them because I saw the 37% too.
right here.
I thought that said hepatocellular and something else on one of the slides.
hmm.
Yeah, there, go,
Oh,
right,
there-
yeah, right here,
I,
I saw the 37%, yeah.
Yeah, it does say 37% there. I don't think I'd have to go back and look and see what the like specific malignancies were.
Okay.
I'm not sure of that off the top of my head.
Yeah, and this is so new and very little data out. I haven't had any experience with it. So I love your presentation, love the monograph that was put together. So thank you.
Other questions? I guess it was interesting to me. I was trying to understand the durability of the treatment and the number of patients that were and in terms of durability, the second study looked better than the first study looked better than the second study. Although I couldn't see any real differences between the population, and maybe I was looking at it wrong, but I think that's still a question, I guess, in my mind. Clarify if the treatment's used, does that preclude them from future transplant?
So this is a good question. So in the exclusion criteria for both of the trials didn't allow patients to have a transplant. I think one of them, I think it was the second study did allow for a previous islet cell transplantation, but no other type. So I know in the prescribing information that donidalorsen there's no evidence, in patients with renal transplant. But in general, the guidance from organizations does recommend, islet cell transplantation may be an eligible option for patients who have previously undergone or are undergoing a renal transplant specifically.
Okay. All right. So Noon, do we have, and I apologize, I'm trying to get back to my, we have committee discussion and questions. Do we have a proposed prior authorization criteria that we want to review?
Yes, we do have a proposed PA criteria.
And then I guess the other question I have in my mind is, have we had any input from any of the endocrinologists, thought leaders in the community around this? I think.
That's a good question. So we have sent this to the managed care health organizations and have received their feedback. And we have incorporated the feedback into this PA. And we haven't received we haven't sent this to the endocrinologists outside of Medicaid. But yeah, we do receive the feedback from the ACO and we have incorporated into this one.
Okay, thank you.
Yeah. So this is the proposed criteria for Glantidra. These criteria for approval is all of the following criteria must be met. The medication is prescribed by or in consultation with an endocrinologist with a specialty in islet cell transplantation. The patient is 18 years of age or older. The patient is not pregnant. The patient has a diagnosis of type 1 diabetes. The patient is unable to achieve target HbA1c despite intensive diabetes management, including the use of multiple daily injection, the use of insulin pump, and continuous glucose monitoring and education. The patient has been compliant with the use of CGM and insulin regimen. The patient has a history of current repeated episode of hypoglycemic unawareness and severe hypoglycemia, defined as at least one episode of severe hypoglycemia in the previous 3 years that require necessitating aid from another person. Patient is able to receive concomitant immunosuppressions and PCP and CMV prophylaxis after each infusion. The patient is up to date with all vaccination in accordance with current vaccination guidelines prior to the initiation of therapy. The patient does not have a history of liver disease, renal failure, or has been a recipient of renal transplant. The authorization is up to 1 infusion. The re-auth criteria is updated letter with medical justification or update chart note demonstrating positive clinical response, or another re-auth criteria is repeated infusion up to 2 may be performed if the patient does not achieve independent from exogenous insulin within 1 year of infusion or within 1 year after losing independent from exogenous insulin after previous infusions. Maximum is only 3 lifetime infusion, including the initial auth. And that is our proposed criteria.
So I guess a couple of questions from me. We say that they have to have not achieved target control using insulin pump and continuous glucose monitoring. Do we have a time frame on that?
That is a good question. I think, as Monet said, there is no specific insulin regimen or management regimen in the prescribing informations. What would be the reasonable, where the board would think the duration that we can look into for this criteria? How long do they have to be been on this? Couple years? We haven't decided.
I guess I'd lean on the physicians in the room in terms of that, but I think there's some time and that needs to transpire, and there's a learning curve to using CGM and the pump. I don't know what that is, but I would think this is not, give it a whirl for a month or 2, and then we're going to jump right to this treatment. I don't see any of the endocrinologists that I know doing that. I just think that maybe there should be a specified time. I mean, I think you could easily say 6 to 12 months. I don't know if that's reasonable. And then the second is really, and I apologize, I've been in 3 different time zones already this week. So we say maximum of 3 lifetime infusions. Do we have data about reinfusion?
I think that is what included in the prescribing information for reinfusion.
Yeah, but until they have data, personally, I say, no, you can't reinfuse. There's got to be some clinical data to support reinfusion.
Yeah, I will just say really quickly, in both of the clinical trials, patients were able to receive up to 3 infusions. So So there is some clinical data on that.
And they have looked at populations where first infusion or people who had the second infusion had slightly better outcomes. So I actually haven't seen studies on third infusions, but I have read some studies on people who have not had as great of an or the first infusion wasn't effective, so they received a second infusion with a better outcomes. So I haven't seen one with the third, but that is on the FDA approval label. So that's interesting, though. It's a good question, something to look into.
Yeah, and I was just going to say really quick, I do have the numbers because there were 30 participants enrolled across both of those trials. 11 or 37% received one infusion, 12 or 40% received two infusions, and 7 or 24% received 3 infusions.
Okay. Dr. Weinstein, you've got your hand up.
Thank you. I'm just looking at the first bullet, which says this care will be overseen by an endocrinologist with a specialty in this transplantation. So, I had the same concern about timeframes, and I would think it might be, going on a year, but I don't know that we would specify that. I don't see people being rushed into this therapy, considering the risks of immunosuppression and so on. But under the guise of the specialist, I think, I don't know if we want to say the time frame's determined or, they've been treatment adherent, in consultation with a diabetes, specialist or something like that. So we know that they're in care that's appropriate prior to this being considered. But we're not saying how long. So that was one thought. On the last bullet for the criteria, I had two questions. So the exclusion criteria I understood to mean any other transplant other than a prior islet cell. Is that correct? And they shouldn't be on other immunosuppressive therapy. They would already be excluded. So is it not only a renal transplant, but any other transplant? Do we need to modify that last exclusion criterion? Thanks.
Thank you, Dr. Winston. The last bullet, the patient does not have history of liver disease, renal failure, or has been receiving a renal transplant. The PI only specific call out renal transplant.
Is there a call out though for concomitant immunotherapy?
They call out specifically that the patient had to be concurrent use with immunosuppression therapy.
Receive concomitant immunosuppression. Okay. So I think, Dr. Weinstein, you make a good point about the time frames. That makes sense to me. I guess the other question here is we say patient is unable to achieve target A1C despite intensive diabetes management. That's making an assumption they're capable of intensive diabetes management. And I guess I'd want to make sure that, somebody may not be capable of that, but is that a reason to go ahead and then use this therapy? Dr. Turner, you've got your hand up.
Well, to your point, I would say if somebody is not capable of intensive management using CGM pump, et cetera, then I would wonder whether they were capable of keeping up with the fairly intensive management of the the immunosuppressant therapy after a transplant, you know, it's really kind of a trade-off as far as intensity of management, in my opinion.
Okay.
The other thing I was going to ask, though, is there is a history of malignancy not a contraindication?
I believe the only contraindication that was called out is only for a patient who has concomitant disease or condition, including pregnancy, that contraindicated to the procedure of lentiviral infusion or immunosuppressions, not the history of malignancy.
That's a really good point, though. Dr. Brenton, you have your hand up.
Yeah, just one thing I was thinking of with this is, I mean, of course, I work with special needs, patients, adults and kids who can't always express autonomic symptoms. I have actually a couple of patients with type 1 diabetes, and we struggle. And so just to the point that I think sometimes there might be a class of patients that, despite using the transcutaneous glucose monitors and the pump, might not be able to manage their diabetes, but they could manage the other regimen because that's done by somebody else, doesn't require their own symptom reports. And so there might be still, some might fit for some people who can't recognize or express their hypoglycemic symptoms, or might have dysautonomia and not be able to really have those symptoms, but still might benefit from other people who can give them the medications that they need. So it still might be that wouldn't necessarily mean that you couldn't benefit from this. Not to say this is it's a new treatment and I don't know a lot about it, but I think that class as being a class of people that might not do well with optimal diabetes therapy, but might benefit from this intervention because other people can help them get them compliant to the treatments.
Okay, we've had a lot of discussion, and we still have agenda items. So with the interest of moving us along, keeping us on time, we've had discussion. I have not heard any real recommendations for changes to this criteria. Are there any specific recommended changes? Sure, that's a good 8 seconds. So I would propose to the group that we accept the criteria as proposed, and that Noon, I think it would be good for this group to hear back. Could it simply happen in the housekeeping section or something in terms of the number of requests that have been received and the number approved, denied, some type of update just to let this group know. I think this is so new, and are being unaware of so many aspects of this that I think, it's something that as a DUR board, we should be monitoring fairly closely, but, let's go with that. That's my recommendation. I'll throw that out there.
Thank you. Yes, I will keep you posted if we receive any PA criteria, any PA requests for this. So far we have 0 requests, and this is really brand new. But yes, I will make sure that I put in like a year updated from now, or 6 month if we receive any.
Okay, do we have a motion?
Move approval of the DUR prior authorization criteria as proposed.
I'll second that.
All right, all in favor?
Aye.
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 Any opposed? All right, the motion carries. All right. I think the second item we have today on the agenda is talk about Vyjuvik for skin conditions. Louis, I think you have the prior authorization criteria there.
Hey everyone, let me present. Okay, can everybody see?
Yes.
Excellent. So we have Vyjuvek, Beramagine, Geperpavec, and that we presented on this last time. So now we have the criteria after giving consideration to the proposed PA criteria submitted by the ACOs. So all of the following criteria must be met. The medication is being prescribed by or in consultation with the dermatologist. The patient is 6 months of age or older. The patient is not pregnant. If the patient is an individual of childbearing potential, the patient is on an effective method of contraception during treatment. The patient has diagnosis of dystrophic epidermolysis bullosa or DEB with genetically confirmed mutations. Documented baseline number and size of wounds. The patient has at least one open wound meeting all the following criteria. No evidence of active infection, no current evidence or history of squamous cell carcinoma. Vyjuvek will be applied to wounds once weekly by a healthcare professional who has been trained in proper application of Vyjuvek. And arrangements have been made to ensure that the patient will be compliant with weekly dosing. The Vyjuvek dose will be determined by the patient's age, wound size, and maximum weekly dose threshold per the United States Food and Drug Administration approved labeling. And then we have the requested dosing to be clear, where the provider can write it there for us. Reauthorization criteria includes updated letter with the medical justification or updated chart notes demonstrating positive clinical response, meaning that there has been achieved complete wound closure and decrease in wound size. And also that treated wounds show no evidence of active infection and no evidence of history of squamous cell carcinoma. The initial authorization will be up to 6 months and no more than 26 doses. The reauthorization same. And that is it. Any questions?
All right, I would open to the committee for any comments or questions around this criteria. All right, hearing no questions, no comments. I'm assuming everyone has some agreement then with the criteria. Is there a motion for approval or non-approval?
I move to approve.
Thank you, Dr. Turner.
I'd second.
Second.
Multiple seconds. Hopefully you guys captured that one for the record. All in favor?
Aye.
Any opposed? All right. That vote appears to be unanimous. And noon, we are now going to move on and talk about opioids.
Yes, let me share my screen. We have just updated our opioid and opioid benzodiazepine combination prior authorization, and we want to share that with the board. And we have also shared this with the ACOs and also incorporate the feedback into this PA. So the first criteria is we want to make sure if the intended use of the opioid or benzo is fit into any of the following situation. cancer pain, end-of-life care, long-term care, palliative care, and sickle cell disease-related pain. These are situations that is an exception to our opioid policy following the opioid guideline. For short-acting opioid, prior authorization may not be required if member has filled initial script of the same medication for 7-day supply or 3 days for dental provider. We ask for clinical rationale for patient who has not been receiving initial 7 days prescription, but request initial prescription of like 30-day supply for short-acting. For long-acting opioid, PA may not be required if member has filled a short-acting opioid within 30 days of initiating therapy on a long-acting opioid. Asking for clinical rationale for member not receiving short-acting opioid in the past 30 days. Asking for a non-opioid pain medication history if the patient is using or has tried and failed at least 2 of the following NSAID, non-opioid analgesics, antidepressants such as SNRI or TCA, or anticonvulsants such as gabapentin or regabalin. Criteria for dose, a pregnancy, MME, and our quantity limit exception criteria. We're asking for the tapering plan must be provided for all limit exception requests. Clinical rationale if patient under 18 years of age receiving a long-acting opioid or more than 7-day supply of a short-acting opioid. Clinical rationale if pregnant patient receiving a long-acting opioid or more than 7-day supply of a short-acting opioid. We ask for clinical rationale for exceeding Utah Medicaid opioid quantity limit and or morphine milligram equivalent more than 90-day MME limit. We ask for detail of the opioid tapering plan or rationale for the lack thereof. For patient who is using concurrent opioid and MAT, asking for clinical rationale for opioid use if patient also receiving an MAT in the last 45 days. For opioid and benzodiazepine combination, this is a FDA box warning. So we ask for clinical rationale and diagnosis for patient receiving concomitant benzodiazepine and opioid within the last 45 days. Asking for the most recent opioid prescription information, such as the days prescribed, medication name, and strange. Ask for the most recent benzodiazepine prescription information, such as the day and name and strange. For non-refer opioid, that is on the non-refer on the PDL. We ask for trying to failure of a refer opioid in the same Utah Medicaid PDL class with an appropriate dose and duration. Clinical rationale for non-refer product, such as the adverse reaction, allergy, or contraindication to the refer product. The provider attests to all of the following: that the provider have signed opioid treatment agreement with the patient. The provider have assessed opioid abuse risk with the validated risk assessment tool, such as opioid risk tool, current opioid misuse measure, or patient medication questionnaire. The provider have checked the Utah Controlled Substance Database with each opioid prescription. The provider have discussed the medication benefit and potential harm, including combining opioid with other CNS depression with the patient. Provider has counseled the patient with high-risk condition such as sleep apnea, pregnancy, mental health condition, substance abuse disorder, or children on the heightened risk of using opioid. The provider has completed a urine drug test for chronic opioid use, duration of more than 3 months, excluding pain management related to sickle cell disease, cancer-related pain treatment, palliative care, and end-of-life care. The patient have received naloxone education and prescription. Initial ask for any of these criteria is up to 3 months, re-audit up to 6 months. For the allowance for the use of concurrent opioid and MAT, only 14 days with no re-audit. That's all our criteria.
All right. We just went through a lot of criteria. Questions from the group? I think given, the significant nature of the problem that we have, I think given the unwanted outcomes of opioids and benzos in combination. At least everything I could see is appropriate. Dr. Weinstein has her hand up and would probably be far more appropriate to comment than me. So, Dr. Weinstein.
Thank you. No, it's a lot to digest, and I just have a question. This final authorization for use with MAT. So this is a PA for concurrent therapy to prescribe opioid agonists with buprenorphine and naloxone. Naltrexone. I'm not sure. I'm a little confused. Apologize.
Oh, yes. Thanks, Dr. Weinstein, for the question. So on the section about the opioid use disorder criteria for approval, our system is set up that in the way that if the patient who is having MAT use any Suboxone claims or Vivitrol claims in the last 45 days, if they are getting an opioid for more than, I think, 7 days, then our system will reject it and they will have to submit this PA because we restricted the use of opioid when patient is on MAT, but not vice versa. If they are having an opioid and they are using MAT, the system will let it go through. Only rejected.
I see. So this is just, I'm sorry. Go ahead.
Oh, sorry. The system only rejected if they are having been on an MAT long term and then using opioid for more than 7 days.
So we're building this in to catch those, I guess I call them overlap prescriptions, where somebody might be starting an agonist therapy with a patient who's already receiving treatment for opioid use disorder with MAT, with a buprenorphine product. So
Correct.
we don't want those to be going concurrently indefinitely.
Correct. Yes.
Yeah. Okay. Just making sure I understood. Thank you.
All right. And if the group didn't see, Monet did answer the question about the malignancies in the chat. Which there were 12 skin cancers, 1 post-transplant, and I'm in South Dakota, so I can't pronounce it today, 1 breast cancer and 1 thyroid cancer. So honestly, you know, I guess the fact that there's 12 skin cancers that seems to stand out a little bit, depending on the definition there. So, okay, back to this criteria. Any other comments? I would move we approve. Is there a second?
Second.
All right.
Second.
Dr. Weinstein, Dr. Turner with the second. All in favor? Aye.
Aye.
Any opposed? Okay. That passes. So noon, I assume that criteria, if it isn't already being used, will be put into use. And in terms of our agenda, I think we have hit the end of the things on the agenda. Next meeting, February 8th. We're going to talk about sublocade adherence and look at a retrospective review of that. Any other messages for the group today before we leave? Not hearing any. I'm assuming everyone's a little tired from shoveling.
Sorry,
Dr. Weinstein, go ahead.
well, apologize. Nana, wondering if you could just email out that opioid PA criteria to us. I didn't see it on the agenda. Maybe because I know we had to.
Yes, I can definitely.
Thank you.
I can definitely email that out.
Okay, thank you, Nan. All right. Everybody stay safe. Everybody stay warm. Wishing everyone a good and prosperous new year going forward. So thank you. We appreciate everyone. Do we have a motion to adjourn?
I'll move, we adjourn.
So moved.
All in favor?
Aye.
Aye.
All right, guys.
Aye.
Bye.
Everybody have a good day. Thank you.
Thank you.
Thank
You too.
everyone.
Bye, everyone.